All right, so we're recording now. Chapter 63, let's start with thyroid disorders. So this is very similar to in idea with chapter 62. All endocrine problems are actually like that. So we always have only two problems.
Excuse me, Mr. Escarda. Could you let Bella in?
Okay, I was saying, the hell was I saying?
You were saying it's all the same.
Who is not muted? All right, let's start over. All right, thyroid disorders. All endocrine problems only have two problems. You either have overactivity or an underactivity of the gland. So let's start with thyroid disorders. One thing to bear in mind also is just like in Cushing's and Addison's disease, the treatment for one can potentially lead to the other extreme. So for instance, when we treated a patient with Addison's disease, they develop Cushing's syndrome, right? And vice versa, when we treated Cushing's disease, the patient developed Addison's disease. So it'll be exactly like that in thyroid disorders. Now, one thing to note is there is a primary and then there's a secondary thyroid disorder. When we say primary thyroid disorders, we're talking about Graves' disease. This is the hyperthyroidism most common type. It's autoimmune. There is a secondary though. The secondary is caused by a pituitary problem, meaning each individual endocrine gland can have its own problem. If that occurs, then it's called primary. However, if the pituitary gland is the defective organ, which is causing either hyperpituitarism or hypopituitarism, it will therefore affect all the other endocrine glands controlled by that pituitary gland. Does that make sense?
Yes.
Yeah, in that situation though, all those disorders that result as a consequence of a pituitary disorder, they are now called secondaries, right? Because it wasn't the gland itself that failed, but rather it was the master gland that failed. All right, so let's talk about Graves' disease. So these are before that, what are the functions of your thyroid hormones? First of all, what are the three hormones secreted by the thyroid gland, Miss Jordan?
Which Jordan?
Janique?
Okay. Can you repeat the question? I'm sorry.
What are the three hormones secreted by the thyroid gland?
I'm not sure.
Okay, so we have T3, T4, and calcitonin. Okay, so T3, T4 are your thyroid hormones. They are controlling metabolic rate in your body. So there's not a cell that it doesn't affect. It basically controls how fast, how slow your body's metabolism is. So if you have hyperthyroidism, you will have oversecretion of those two hormones, resulting in the key features enumerated in chart 63-1. So imagine the most active, restless person you can see. So every single cell in your body will have a high metabolic rate. So let's start with the skin. The patient therefore will have hyperactive sweat glands, resulting in severe sweating, Skin will be moist most of the time and warm also, because again, of course, because of the increased metabolism, you start losing hair, and it's not just on your head but everywhere. Okay, you start losing hair everywhere. Cardiopulmonary symptoms will have tachycardia and high blood pressure. In fact, during a thyroid storm, or which is a thyroid crisis, the patient may develop a hypertensive crisis, or may develop or have a stroke in the process. GI symptoms, the patient will have increased stools to the extent that it will become watery. They have increased appetite, but yet they will lose weight. These patients will constantly be in a negative nitrogen balance, because it's not like they can eat 24 hours a day. They have to sleep sometimes, right? They have to stop eating sometime, but then yet their body just burns through all those calories. So that's why, despite the high PO intake and the frequency of meals, they will still lose weight. Neurologic symptoms are the following. The most distinct feature is exophthalmos. The patient will have it's actually more of an illusion, because what causes the protruding eyeball, or the startled eyes look, is really the eyelid retraction. So if you try pulling your eyelids back, you will also look the same. We have a picture shortly to show you. Because again of the increased metabolic rate, the patient will have heat intolerance and always have a low-grade fever. But again, because the patient is in a negative nitrogen balance, fatigue will result. Psychological, the patient will have emotional instability, so they go from one extreme to the next. Reproductive changes will be amenorrhea, increased libido, but they may not be able to conceive because of the amenorrhea. Others not otherwise, belonging in other systems are the following. Now, goiter here will appear both in hyperthyroidism as well as in hypothyroidism. So we'll discuss later why hypoactive thyroid will also potentially develop goiter. I already mentioned this. The patient will be in a negative nitrogen balance, as well as hyperglycemia. Feel free to interrupt me anytime, okay? All right, let's go now to the causes, by the way. Mainly, where's Graves' disease? Okay. The main cause of the most common type is autoimmune, which is again Graves' disease. Other secondary causes are an increased intake of iodine. Let's say you're drinking betadine, for instance, for breakfast, lunch, and dinner. Of course, that's exaggeration, but that's a constant exposure to iodine, either in your diet or through skin, for instance. Iodine is iodine. It can trigger thyroiditis or hyperthyroidism as a result. Signs and symptoms we already looked at in chart 63-1. So this is the startled eye look, exophthalmos. So this will make the eyes prone to injury. You see what's missing here is the eyelid. So you don't have an eyelid here. It's retracted. So we will have to protect the eyes at night to prevent corneal abrasions or drying of the eyes.
Professor, so they will sleep with the eyes open, basically?
I just put a eye patch over it. It won't be like a pirate though, but you have to cover both eyes. because of the same, because the eyelids here cannot completely cover the eyeball, the eye will be very irritated, they'll get dry, have a bloodshot or tearing, excessive tearing and bloodshot appearance, and also photophobia as a result. Please read eyelid lag and global lag on your own. It's not really significant. So here's the goiter. The goiter in hyperthyroidism is easy to explain because, of course, you have a very hyperactive thyroid gland. So, of course, it will grow. Okay, the more active it is, it will grow. The reason for the enlargement is just like the same reason why a penis would have an erection. So increased blood flow to the thyroid gland will cause it to enlarge. So for that reason, we cannot do surgery if the gland is that big, because what's making the gland that big is the increased blood flow to it. So there is massive vasodilation there happening in the thyroid gland. That's why it appears so big. So in order to safely perform thyroidectomy, the patient will have to be given medications first to shrink the thyroid to a considerable, almost normal size before we can take it out. We'll explain pre and post-op.
And again, Professor, sorry to interrupt you. That's the case for both type of goiters, or the goiter just present in hypo?
No, this is the hyperthyroidism part. So we'll get to the goiter and hypo later.
Got it. Thank you.
Psychosocial, we already explained that the patient will have mood swings, hyperactivity, decreased attention span. They'll be like moving like a chicken. Have you ever seen a chicken move? If you haven't, go find a chicken. Okay, see how a chicken moves. Laboratory profile. Chart 63-2. We will come back to this later when we get to hypothyroidism. So here you have increased T3, T4 in hyperthyroidism. The only ones I want you to memorize, which will be on the exam, are T3, T4, and free T4, and then the last TSH here in the last row. This TSH here. While we're here, let me explain this first. So in hyperthyroidism, you have a hyperactive thyroid gland. So of course you will have an increased levels of T3, T4, and free T4. The TSH though, because our body works by negative feedback, so if we have high levels of T3, T4 in Graves' disease, therefore the stimulus will be lower coming from the pituitary gland. So since TSH comes from the pituitary gland, the TSH level here will be low because there is really no need to stimulate the thyroid gland to produce T3, T4 because it's already in very high levels. So again, in primary hyperthyroidism, which is Graves' disease, the TSH will be low because there is, again, no more stimulus for the release of TSH because the T3, T4 levels are already very high. However, I mentioned earlier that there is secondary hyperthyroidism, right? So this one is a pituitary problem. So if the pituitary gland is the one that's causing the hyperthyroidism, the TSH there will be high, as well as the T3, T4 will be high. That is the only situation wherein the TSH is high, the T3, T4 levels are also high in secondary hyperthyroidism, which is again caused by a hyperactive pituitary gland. So nothing is wrong with the thyroid gland, therefore. Okay, so in hyperpituitarism, it's the pituitary gland that is hyperactive. causing high TSH levels, causing also high T3, T4 levels. Does that make sense?
Yes, I have a
Yeah.
question.
Go ahead.
For the increased intake of iodine, which is also a cause for hyperthyroidism, would that hyperthyroidism will be primary, secondary, or tertiary?
That would be more, I really don't know where that falls because secondary is caused by the pituitary gland. So I guess that would be tertiary.
Okay.
It is now caused by increased intake, or otherwise it could also be drug induced.
Okay.
Professor, I think I have different values in my book.
So do I. That's what was going to be my question.
So do I. Same
TSH.
thing. Yeah, I was gonna say.
What where
For
was
the
it printed?
TSH,
Uh-huh.
the
TSH.
very bottom, mine says 2 to 10 rather than 0.3 to 5.
Is it the same units though?
Yes. Same units, 2 to 10. Same units. And then it says, yeah, 2 to 10.
Oh.
Same.
Same in here.
Yep,
The ninth
Say
edition.
about that. Where was
yeah, the same.
was that printed from China?
This is a 9th edition.
Ninth position.
That's where it's made from, made in. No, I don't know what to say. Let me review because this is what the ebook is showing me, but I'll send you the numbers. Okay.
Thank you.
But what does yours say? 2 to
2 to 10.
2 to 10. Okay. All right. I took note of it. So that's the labs. For diagnostic testing, we use, there are a few. One is a thyroid scan. In a thyroid scan, we use a radioactive iodine. This is a lower dose though. This is called RAI 123. There is another radioactive iodine, this time used for treatment. If you remember in chapter 22, when we discussed radiation therapy under cancer treatment, that radioactive iodine used for radiation treatment was RAI 131. So that one was different. That was obviously a higher dose. So this one's a lower dose. This is PO. So we give it to the patient usually a day before, and then the thyroid gland, of course, will take it up because there's no other gland or organ in the body that uses iodine. It's only the thyroid glands. So the next day, we take the patient down to radiology and perform a thyroid scan. So depending on how much of it was taken up, so normal intake is uptake is about 5 to 35. Anything higher than that, then of course that means you have a very hyperactive thyroid gland and therefore confirms the diagnosis. Ultrasound can also be done just to check if because it could be a smaller percentage of hyperthyroidism is caused by a tumor. So it may be thyroid cancer causing the symptoms of hyperthyroidism. The ECG won't be used to diagnose, but rather to see the cardiovascular effects of the disease on the patient. Interventions now. Most patients will end up with surgery. However, like I said earlier, it's not going to be fast. We have to shoot the thyroid first. So before surgery can be done, let's do non-surgical first. Preparing for an emergency, which is also possible preoperatively and may occur intraoperatively, is a condition known as thyroid storm. So this is the equivalent of acute adrenal crisis in Addison's disease. So this is a life-threatening situation. This is characterized by high fever and high blood pressure. We'll discuss, there's actually an entire chart dedicated to thyroid storm management. Here is a warning that when a patient with hyperthyroidism is hospitalized, always monitor the temperature. because the trigger for the thyroid storm is stress, and you know stress is very broad. Anything could be perceived as stressful. So we're not talking about environmental and physical stressors here, like trauma, surgery, or hospitalization, but also emotional triggers or psychological triggers. When the patient is admitted, we reduce stimulation. So that means keep the door shut. Noise should be kept to a minimum. Lighting could also be dimmed. We encourage rest because at any time they could develop thyroid storm. Because the patient has heat intolerance, so we do cooling measures, keep the temperature, room temperature down. We give them ice packs if needed. Well, they're already wearing a semi-private gown, so no problem there. Although we can encourage cool showers or sponge bath if they do have enough energy to do that, but if not, then assist the patient. And as far as the eyes, we will have more interventions under the intervention section. Okay. But right now, only artificial tears are mentioned. We'll have more later under the interventions. So patients will undergo drug therapy first before they go to surgery. Drug therapy are two. We have thionamides, and then we have two thionamides, PTU and methimazole. Then we have the SSKI or local solution of potassium iodide. All right, these two drugs are used, but if you noticed earlier, how old are the patients who develop hyperthyroidism? What's the incidence? They are women of childbearing age, right? So under incidence,
Yeah, between 20 to 40 years.
yeah, so those are childbearing age. So these drugs are teratogenic. So check first for pregnancy before you start the therapy. So very important, these drugs are, there's a drug alert here, right here. So methimazole, between PTU and methimazole, this thing is category X because it causes birth defects during pregnancy, okay? So warning. So therefore, while on it, they should be on two methods of birth control. Two condoms. Some?
No.
Okay. So two methods. Okay, you should have a backup. PTU has its own problems too. It causes liver toxicity. So this is a drug chart. So the testable part is always the second column for nursing implications, right? Have fun with that. Here's a frequent side effect: weight gain, slow heart rate, cold intolerance. These are all symptoms of hypothyroidism, meaning the drug, these ionamides are so potent that they literally could lead to the other problem. So these are now symptoms of hypothyroidism. The drug also, it lowers the immune system, so avoid crowds. And here is the liver toxicity. So watch for darkening of the urine and yellowing of the skin. All right. Now, remember we said earlier that iodine can cause hyperthyroidism, correct? So these patients will receive a saturated solution of potassium iodide. Although this is not purely iodide on its own, it's potassium iodide, it's still iodine. So when given alone, can it trigger hyperthyroidism or even thyroid storm? Yes?
Yes.
Yes, okay. So be careful when administering this. It should only be given 1 hour after the thionamide because this version of your edition of your textbook eliminated the drug action, but PTU and methimazole inhibits binding of iodine in the thyroid gland. Since that is their action, giving this drug 1 hour after this will prevent the iodine here from binding in the thyroid gland. Does that make sense?
Yep.
Okay, so you inhibit first by giving the thionamides, either of these two, and then 1 hour later, give the SSKI. Here are some unpleasant side effects here. By the way, there's really, I tried looking why we would give potassium iodide in the first place when this can trigger hyperthyroidism. I couldn't really find a clear explanation. The closest I got to was if theoretically, you know how when you're full, let's say you're at a buffet and then I give you even more food, what will you say if you're already bloated? You've had 3-4 trips already to the buffet table and then I shove down even more food down your throat. What will you do?
Nothing.
Throw up.
Well, it's not like you can't defend yourself, right? So you will say, no more, right? So you say, no more. So theoretically, that's what we're trying to do here. So we're trying to flood the thyroid with lots of iodine until it says no. So therefore, it will, theoretically, it suppresses the action of, or activity of the thyroid gland if you flood it with too much iodine. Does that make sense?
Yes.
Again, that's the theory behind it, though. That's why they give saturated iodine solutions. Okay. The only use, by the way, the only time we're using SSKI is if we're preparing the patient for surgery, meaning it's not part of regular treatment. Regular treatment, if we're not planning surgery, is the thionamides. Okay? These are the only two we give. However, if we are preparing the patient for surgery, then we add the SSKI. And this is not given long term. This is only given 2 weeks, I think. The book says 2 weeks. And then the patient gets surgery after that and then no more.
Professor, what about the Lugo solution?
That is the SSKI.
So they're the same exact thing, just different names?
Well, the name of the Lugo solution is SSKI.
Oh, so it's the same thing.
Yes, that's the same.
They're two separate things. Okay, thank you.
No, they're not. It's the same.
Okay.
Okay, here. So pre-op, we give the iodine preparations for approximately 2 weeks. We should see an improvement. The thyroid gland should begin to shrink together with the thionamide therapy. And beta blockers are given here, although beta blockers have nothing to do with the thyroid gland itself. However, this drug is used to relieve these symptoms, the adrenergic symptoms caused by the hyperactive thyroid gland, the high levels of T3, T4, which will make the patient really nervous. Here, these are the symptomatic effects, high heart rate and vasoconstriction. So these are very uncomfortable feelings. So the patient will be put on propranolol. Among all other beta blockers, this is what they use. All right, another option, like we said, is RAI. We discussed this already, at least I know we did in third semester. If you haven't, then please review again. There should be a chart in this chapter. So the therapeutic radioactive iodine here is the RAI 131. Please take note about your education. There will be questions about patients asking you when they can expect improvement. So this thing will, after treatment, you won't see the benefits until 6 to 8 weeks later. Okay, so the patient just needs to know the principle is the same as with in chapter 22. So when exposed to radiation, some cells die right away, but then all cells that absorb the radiation will die later. Okay, because this is not a very strong radiation. Okay, this is taken by mouth. So unlike external radiation therapy, wherein the dose is really strong, very high, this one is so low. The dose is low. That's why it takes also a long time to work. Okay, here are your, please review this chart 63-4. RAI 131 falls under unsealed radiation. So since it's unsealed, therefore it enters body fluids. So anything coming out of this patient are radioactive for at least about approximately 2 weeks. So that's why these are the precautions. So anything wet, so urine, feces, saliva, vaginal secretions or semen are all radioactive here. So you take precautions on all those fluids, especially here, the patient is incontinence, then take care. Those, anything, again, urine is considered radioactive here. We give laxatives because if they get constipated, it may damage the bowels because, again, the feces contain are also radioactive. So we want feces to be moving and not staying longer than necessary in the bowels. Please, again, read the rest here, including this one. I don't really know why they put this here. But I guess I remember my wife telling me about a lawyer that she worked with that ate leftover chicken wings of her colleagues. I think she told me a story about that. That a guy on the table didn't eat the chicken wings very well, just left it on the plate, and then she went, "Are you gonna eat that?" And then she went and grabbed the chicken wings that still had some meat at the at the tip, and finished them off clean. Surgery.
And
Hello? Yeah.
what happened?
What happened to what? Are you talking to me?
Yeah, you're telling us about a chicken wing story. It was radioactive, and then so what happened to that person?
Oh no, that was just a lady eating leftover chicken wings. I didn't say the guy was treated for radiation.
I thought you were relating the story to. Okay.
No, I'm just saying that there are really people like that. I didn't think there would be. I mean, why would you finish somebody else's chicken wing that they already put in their mouth? Okay, so surgery. Thyroidectomy can be total or subtotal. I already mentioned about the 2 weeks of iodine preparations. Okay, our purpose there again, along with the thionamides, is to shrink the thyroid, make it as normal as possible. Because remember, bleeding, okay, so that will decrease the vascularity. So therefore, we have less risk of hemorrhage during surgery, and also with thyroid storm. So if the thyroid glands are close to normal, then the patient's not at risk for a thyroid storm. If any of these occur, we manage them. The patient will also be given a really good meal for up to a week before surgery, because remember what is their protein status? They are in a negative nitrogen balance, right? So they're severely undernourished. They're losing weight, so therefore they need to, so to say, you fatten up the patient. Okay, get them ready before surgery. I do the post-op exercise teaching during pre-op. So explain to them that the incision will be in the throat. So you'll have someone, you're literally slicing their throat. So this is right above the sternal notch. Okay, the incision would be about maybe 4 to 5 inches. And because the incision is going to affect the trachea, so airway will be a problem, could potentially be a problem post-op. And because the parathyroid glands are attached to the thyroid glands, so they'll end up being removed also during surgery. So we will have hypocalcemia as a result, because there's only one function of the parathyroid glands, which is secreting the parathyroid hormone, which increases calcium levels. So that's the one job of the parathyroid glands. So the parathyroid holds parathyroid hormone, increasing calcium levels when needed. And then the thyroid glands hold calcitonin, which is going to lower calcium levels. We'll skip operative procedures, nothing testable there. Let's go to post-op. So immediately after the patient comes out of surgery, our responsibility is to monitor for complications. So mentioned pre-op are the possible complications are airway compromise. We talked about hypocalcemia here because of injury or removal of the parathyroid glands. And then we also have laryngeal injury potentially. And then fourth is, of course, hemorrhage. Positioning. The patient must be put on a pillow, because when you imagine it, if there's no pillow, then that means the patient's head will be hyperextended. So therefore that will put strain on the fresh incision. And we don't want that, because when you put strain on the incision, remember that's close to the airway, that might cause swelling and edema, blocking your airway. This is a given for every patient, so we do that anyway for any post-op patient. Here is the hypocalcemic episode. The severe form, though, will be called tetany. And you learned this previously. What are the two signs of tetany?
The one, the trosion, the cough stick, or whatever it is pronounced.
Okay, so that's
Like a twitching?
okay. So the carpopedal spasms when your arm and wrist flexes, right, and twitches. That's called trousseau sign. What about the one for the cheek?
Kosava, something weird.
Chevostek sign.
That.
Okay, so you check for those two things early post-op. So that will indicate hypocalcemia. We'll get to the intervention shortly. Hemorrhage, especially during the first 24 hours. There's a, and this is common in every textbook, they tell you to check the dressing behind the neck. Because by gravity, of course, bleeding will go down behind the neck. This is a emergency. So when you hear stridor, then that's a sign of the airway closing. So what do we need to keep at the bedside for a post-thyroidectomy patient? What equipment should you have there? Should any of these things occur?
Intubation equipment,
We need oxygen, suctioning at least.
tracheostomy equipment.
tracheostomy equipment. Don't worry about the intubation because the crash cart is always nearby, but at least keep a tracheostomy equipment, okay? Because we might not be able to, let's say, the stridor really close the airway, so the laryngoscope won't be able to pass anymore. So we may end up with tracheostomy instead.
I have a question.
Go ahead.
So, like after surgery, what would be like the first thing the nurse should check? Is it hemorrhage or is it respiratory?
Of course, our acronym is always ABC, right? So we put airway first, and I guess circulation, which is hemorrhage, will be second. So watch for this, and this, and this. All of them, actually. It'll be easy later when we get to parathyroid disorders, because in hyperparathyroidism, the treatment is also surgical removal of the parathyroids, which is exactly where the thyroid is. So same surgical incision, same post-op care. All right, so early signs of hypocalcemia are, of course, the tingling around the mouth. We'd rather not see the Trousseau or the Chebostic sign because those appear when the calcium levels are severely low. So we'd rather assess the earlier signs, which are tingling around the mouth or toes and fingers, as well as muscle twitching. Here is your treatment: IV, calcium gluconate or calcium chloride. Laryngeal nerve damage, as stated here, it's usually temporary. However, since it may be misinterpreted as stridor, okay, when you have, because this patient has hoarseness of the voice, so sometimes it's difficult to distinguish, is this patient having stridor or is this just the hoarseness? Either way, just carefully monitor the patient. So here is thyroid storm, which can occur at any time when the patient has hyperthyroidism. These are again the key symptoms, so the fever, tachycardia, and the severe systolic hypertension. This is life-threatening. Patient could go into cardiac arrest or stroke, whichever happens first. And here's the warning: it's always the temperature, the rise in temperature, that is your warning sign. Here is the emergency management as promised, chart 63-5. So ABC, and then give your thionamide followed by your Lugol solution. And then, and then here's propranolol for the adrenergic symptoms, the sympathetic symptoms that the patient will manifest. Give steroids, high dose steroids. Look at how many these are, 100 to 500. And of course, they should be on a cardiac monitor. And for the heat intolerance, cooling measures, and normal saline. If needed, we can also cool down the saline, like wrap it in ice, so that would also help decrease the temperature. Eye management. So here we have, earlier we had artificial tears. Here we have now dark glasses, as well as taping the eyelid shut bedtime. Do so gently though. And okay. Yeah, that's it. Any questions on hyperthyroidism? Alrighty then, let's go to hypo. So one of the causes obviously is treatment for hyperthyroidism. So either the antithyroid medications, the thionamides, or surgery will put the patient in hypothyroidism. And this is very simple. As you saw in Addison's disease, how did we treat the patient in Addison's disease? What did we give?
The hormone replacement?
All right, so we gave the patient hydrocortisone, right, for life. This one also, the patient will be given levothyroxine. So they're unable to produce T3, T4, so we give them the T3, which is levothyroxine. All right, go back to the labs again. Forgot what table that was.
63-2.
Okay, very good. Page 1266. So here is hypothyroidism. T3, T4, and free T4 are all decreased, but look at your TSH. TSH in primary disease will be high. Okay, so completely opposite in Graves. However, in pituitary disorder, which is secondary, so it is the same. So your T3, T4, and free T4 are low, so is your TSH if it is caused by a pituitary problem. All right, so chart 63-6 now. So these are again complete opposites in hyperthyroidism. So if you had heat intolerance there, you will have cold intolerance here. You guys can read this on your own. You're very good at this. So cardiovascular symptoms, the opposite from hyperthyroidism. Still, you have the other extreme though. So if you had really, short attention span in hyperthyroidism because the patient is very hyperactive, like the chicken, this patient now has apathy. So this patient wouldn't care. So they have weight gain, constipation instead of diarrhea. They'll have abdominal distension, no appetite. And besides having no appetite, they still gain weight, okay, because the metabolism is just so low. Neuro-wise, cognitive functioning will be slow. They'll be slow to respond to you. And there is another complication here. So if we had thyroid storm and hyperthyroidism, we will have mixed edema in hypothyroidism. This is a typical appearance. The tongue enlarges for some reason, so large that it doesn't fit in the mouth. So most people will, most patients would present like this. The tongue will be protruding out. I mean, they can still put it in the mouth, but at rest, so it tends to protrude like this. There will be edema. Here you have periorbital and facial puffiness, which is manifested here. You can see this. You also have goiter. Okay, so the goiter here is said to be a result of the high TSH level, meaning because the T3, T4 levels are so low, the patient's pituitary gland will continually release TSH, and the continual push there, the continual stimulation caused by the thyroid stimulating hormone will cause the thyroid gland to work over time. However, it will be futile because no matter how it tries to produce T4, it will be unable to. So here you have, just like when you're flexing, let's say you're working out. Okay, so you are doing weights. Okay, so it's like that. So the TSH, the high TSH levels causes the thyroid glands to work more. So it is in this instance that it enlarges, but this enlargement though is not caused by vasodilation and increased blood supply or blood flow. Okay, this is the main difference between the goiter in hyperthyroidism versus the goiter happening in or developing in hypothyroidism. So here's mixed edema. We also will have a chart for this because this is also life-threatening. The common cause of death here is shock. The patient's blood pressure will be so low because remember the patient already has bradycardia. It will slow down further to the point that the patient's cardiac output is affected. We know the primary causes. If it is Graves' disease in hyperthyroidism, here in hypo, it's called Hashimoto's thyroiditis. Also an autoimmune problem. Others are, of course, secondary, meaning treatment for the hyperthyroidism. No, it occurred secondary, so that would fall under iatrogenic, right? That's the term you learned in fundamentals, meaning it resulted as a result for another treatment or another procedure. All right, we did the signs and symptoms already. You can read these for the explanation. I'll go straight to interventions. Here's the cause of death I mentioned earlier from mixed edema coma. So it's either respiratory failure or shock. Here's a warning that the diaphragm is also a muscle. So when these patients have muscle weakness, please remember that the diaphragm is also a muscle. So the patient may go into respiratory failure. Just like in Addison's disease, how do we treat hypothyroidism? We gave the patient hydrocortisone. In Addison's, what do we give this patient?
Levothyroxine.
Right, so there's only one drug, levothyroxine sodium. There are many brands. There's Armour Thyroid. The most popular is hold on. Let's tell her to refresh. One thing to note though is that this is the principle when starting thyroid treatment. The acronym will be ALARA, A-L-A-R-A. So we start the dose as low as reasonably achievable, meaning we start with a low dose that will meet the patient's metabolic demands at the lowest dose and then go high, increase the dose very slowly as well. Okay, so we go slow, start low, go slow, or as far as dosing is concerned, as low as reasonably achievable. The reason is, especially if the patient has a history of cardiac disease, it may cause cardiac problems. It may cause or trigger dysrhythmias if the dose is started too high. Plus, you know for a fact that our hormonal needs don't really stay the same. I mean, when you get pregnant, for instance, it changes, or after the birth of the baby, it changes again. So let's say you are in school, you are in when exams are happening, so your hormone needs change again, right? Because metabolism again increases. So it's constantly checked and adjusted by the physician. So there's no such thing as once we hit the dose that is meeting the patient's needs, it will not stay the same. So periodically, again, a few months later, it may be too low or even too high. So it's constantly checked. Okay, so these are again our main observations. Now take note that the patient could potentially also develop hyperthyroidism when the dose is too high. Okay, so watch for those. Here are your problems that can result from mixed edema. most common causes of mixed edema are the following. So we have acute illness. So just like in adrenal crisis or in thyroid storm, or even in DKA. Okay, the patient got sick, or they couldn't take anything by mouth. They stopped their hormone replacement therapy. Okay, or whatever reasons, or if the patient used too much sedatives or opioids. These are obviously seen as depressants, which will slow everything down. And there's also a warning here that you should use these drugs cautiously. When you give sedatives or opioids, you give them cautiously because the patient may go into mixed edema. I mentioned this already earlier. So on top of your respiratory failure, shock could also result. And we'll discuss more on shock later in week 13. So here's your hypotension here, respiratory failure. So just read the rest. So here's the cold intolerance and the hypoglycemia. We had hyperglycemia and hyperthyroidism. And just as promised again, here's a chart for mixed edema. Of course, when the patient presents with these, they're already in coma. Okay, although coma here in mixed edema is a late sign, meaning the earlier consequences would be respiratory failure, hypotension, hyponatremia, hypothermia, and hypoglycemia before they go into coma. But either way, the patient's unconscious when they're in mixed edema. So therefore, we cannot shove down any pills. So the levothyroxine here has to be IV. And we give fluids for fluid support and hemodynamic support. Here's for the hypoglycemia. Again, this is again for hypoglycemia, for hypothermia, hypotension, and here's for hypothermia again. Right? Then because the patient is unconscious, always institute aspiration precautions. There are two practical. Patients should understand that the hormone replacement is for life. Okay, just like in what happened in Addison's disease. There are. Where am I looking for? Oh, right here. So teaching. So read the rest, especially about nutrition and all that. Thyroid hormones. They should be taken on an empty stomach. It's given once a day. So this should be 30 minutes before breakfast at least. And at home, these are two very practical ways to monitor the need for dose adjustment. Thank you for reading, Ms. Bitoy.
Teach the patient to monitor himself or herself for therapy effectiveness. The two easiest parameters to check are the need for sleep and bowel elimination. When the patient requires more sleep and is constipated, the dose of replacement hormone may need to be increased. When the patient has difficulty getting to sleep and has more bowel movements than normal for him or her, the dose may need to be decreased.
Okay, so easy enough, right? So the patient could develop hyperthyroidism here, or they could go into mixed edema if the dose is too low. And that's it. Short and sweet. Any question? We will not cover thyroiditis. Let's take a short break. Come back at 7:45. Sounds good?
Okay.
Yep.
Parathyroid disorders are really short because there's only one problem here. Since the parathyroid hormone only controls one electrolyte, has one job to do, which is to raise the calcium levels. So what the parathyroid hormone does is it acts on the kidney, causing kidney to reabsorb calcium and excrete phosphorus. Okay, it has one job. Therefore, if you have hyperparathyroidism, what is your main problem?
Hypercalcemia.
Hypercalcemia. That's it. So let's keep this short. We'll have no. Well, this are usually a tumor or autoimmune, right? But so either it's a tumor causing a deficiency or a what is that? Or autoimmune. All right. Signs and symptoms are those of hypercalcemia. To make it a little easy, I won't go back to chapter 11 for the complete signs and symptoms of hypercalcemia. I'll just take them from this textbook, this chapter here. Also, I won't test you yet on the EKG changes of hypercalcemia. We'll do that when we reach chapter 34. We'll come back to chapter 11 for that. All right, so here are your manifestations. So you have GI problems are the following. For the muscles, the patient will have fatigue, lethargy. There will also be muscle weakness. You could have calcium stones in the kidneys. What else? We have loss of bone density because again, the calcium is also broken down from the bone here. So the patient will have weak bones. This should be the same in your book, I hope, not different. Is it the same? Unlike the one we had for
The same.
Okay, very good. All right. So we will only do the total calcium. Okay, no need to memorize the ionized calcium. Ionized calcium is the free calcium. This is the calcium that goes in and out of the cells. That's free calcium. So only the total calcium, which is the most commonly used for on all the tests I've seen anyway. So in hyperparathyroidism, of course, that's high. And so only 3. So we'll test calcium, the total calcium, phosphorus, and magnesium. So it's always opposite with phosphorus and calcium, okay? It's easy to remember. And then, of course, it'll be the other way around in hypoparathyroidism. But we'll return there later. Interventions. So what are the interventions for hypercalcemia? Let's start off with diuretic and hydration. This is not counterproductive. Actually, these two supplement each other. Diuretic, even if given IV, will take at least 30 minutes to an hour to work to excrete the calcium. So the fastest way is large volumes of fluid. So we'll give saline. So that's the hydration there. Large amounts of it. So bolus, fluid bolus with saline. So that will dilute the bloodstream, so lowering your calcium levels instantly until the furosemide eliminates the calcium. All right, so they're actually working together. Then we have drugs to lower calcium level. So one is Calcet. You've probably seen this in another disorder in last semester, or maybe not. Okay. If unresponsive to Calcet, then you'll give oral phosphates, because again, if you have phosphates, then you'll excrete calcium and vice versa. And this is done to inhibit bone resorption. That way you don't have further breakdown of calcium from the bone. Take note that IV phosphates are only used when calcium levels are severe, when you really want to lower it fast. Here's calcitonin. So this is the hormone released by the thyroid glands. So that one will cause increased excretion of calcium. So just please take note of how each drug works, okay? Beginning with cinacalcet. So does it shift potassium? Does it lower the bone resorption, or does the drug excrete calcium? So please look at each one, because I remember the question on the exam was specific, whereas whether it generally lowers calcium or does it promote calcium excretion. So take a look at which drug does which function or has which effect. Hypercalcemia, of course, will cause cardiac dysrhythmias, so they should be on a cardiac monitor, just like with hyperkalemia or hypokalemia. Because the patient has weaker bones, you should institute for precautions. Surgery, this is what I mentioned earlier. When there is a need to remove the parathyroid glands, then the nursing care before and after is exactly the same for thyroidectomy. So we won't repeat that. So whatever pre-op care you did earlier, the pre-op teaching, for post-op exercises, the pillow, the positioning, watching for bleeding, airway compromise, tetany, all the same. So of course, we expect the patient after surgery to have hypoparathyroidism now, in which case the patient has hypocalcemia. So just get the calcium gluconate or calcium chloride IV ready post-op if it occurs. And that's really it. Any question before I go to the opposite? All right, so let's go to hypoparathyroidism. So exactly opposite. There are 3 different types. Regardless of the cause, the patient still develops hypocalcemia. So let's go to assessment. What are the signs and symptoms of hypocalcemia? This was already discussed in post-op care under hyperthyroidism. So after thyroidectomy, we watch for tetany, right? So it was already described there for early versus late signs. Remember that tetany is already a late sign of hypercalcemia, or otherwise stated, it's a sign of severe hypocalcemia. So while the levels are mild to moderate hypocalcemia, these are your signs and symptoms, which again were already mentioned under thyroidectomy. Here are the spasms. I believe the term used there was muscle twitching. Okay.
Professor Sparta, sorry, Sheena's trying to get in.
I'm sorry?
Sheena's trying to enter. She's unable to get back into Zoom.
I don't see anyone in the lobby, so I can't let anyone in if I don't see them. I mean, even if I wanted to.
Okay, I'll let her know.
Yeah, she's not showing up in the lobby. Okay, now she is. Okay. All right, let's go to intervention. So similar to hypothyroidism, how do we treat hypoparathyroidism? How do we treat hypocalcemia? By
The calcium and the vitamin D.
All right, so we replace it. So we give calcium and vitamin D because they go together. We cannot absorb calcium without vitamin D. It also depends on the cause of the hypoparathyroidism. If it's caused by hypomagnesemia, then we replace magnesium. If it's a vitamin D deficiency, then we give calcitriol, which is vitamin D. For calcium replacement, take note that the range is 0.5 to 2 grams, so that's 500 to 2,000 milligrams daily. However, please take note that this should be divided. You can't dump 2 grams at one dose. So this is going to be given in 4 doses. So breakfast, lunch, and dinner, and then 1 at bedtime. Diet-wise, please take note here. Although most of us will probably think, that dairy products are all high in calcium, which is true, but particularly milk, yogurt, and processed cheeses also have high phosphorus though. So that is contraindicated. And just like with hypothyroidism, this hormone replacement are going to be lifelong. I mean, they won't be able to be rid of the hypocalcemia because they don't have their parathyroid glands anymore. So they have no capacity to reabsorb calcium at the kidneys or break down calcium from the bone, okay, because the parathyroid glands are gone. So no parathyroid hormone. So we'll just have to replace the calcium. And that's it. Short and sweet. Any questions, future nurses?
Nope.